RedLANO, Red Latinoamericana de Neuro-oncología.
Thank you again for this invitation, and I'd like to discuss the role of radiosurgery in glioma. And it's a technology that's becoming more available, and it is something that we have some information about. So essentially, this is just a table summarizing why we use radiation for glioblastoma and anaplastic astrocytoma. And this is going back historically, looking at the results from the late 60s and the early 70s, showing that the use of radiotherapy increases median survival. So this is something that has been the foundation of all subsequent trials, that radiation is part of our standard of care. And the role of chemotherapy has also been somewhat established through historical trials and more consolidated more recently with the Stutch study. So this is a graph that I showed before, but essentially what it showed was that there was a difference in these 358 patients, that radiation made a difference in the outcomes of the studies of these patients, although you can still see that the vast majority of our patients die within 2 years. So what have we learned through our experience? We know that there's a dose effect of radiation, that 60 gray has been established as our basic foundation for radiation, and part of the reason is studies like this that showed the 60 gray survival curve was better than 0 gray, 55 gray, or 50 gray. And essentially that has actually set the industry norm for how we have proceeded with radiation. And also at the 60 gray, the risk of toxicity is acceptable. It's less than 5%, and so this has really become the foundation. Now, there have been efforts to look at dose escalation over the last several decades, and one of the most intriguing studies is this dose escalation that was done with proton therapy that was looking at 90 gray. Now, this is increasing by 30%. And the intriguing information from this study was that all of these patients developed toxicity. There was new enhancement in that area, yet at the time of surgical evaluation, most of the abnormality was necrosis. And those patients who did have necrosis actually survived longer. So this was some information suggesting that the 90 gray may actually improve survival, but at the same time toxicity was quite large, and therefore the balance of the therapeutic index was somewhat impacted. Other efforts have been looking at hyperfractionation, and this was a series of studies done through the RTOG. And again, really no major benefit was found with hyperfractionation. And the theory behind hyperfractionation is to deliver more radiation so there may be some more benefit to the glioma cells. And you can see here 72 versus 60, 72 gray in 60 fractions, so that's 1.1 gray BID. And dose escalation studies, again, here really didn't show a benefit. So one of the things that really has been established, again, through all of these studies, that practically 60 gray is where we're stuck. Radiotherapy volume has been another issue that we've looked at, and this is a study that was done at MD Anderson looking at whole brain radiation versus partial brain radiation. The old studies that were done in the 1960s and 70s, that was actually looking at whole brain radiation, and since then our volumes have become more and more defined. And here was one of the earlier studies that showed that we don't have to do whole brain radiation and that local fields are acceptable. So what we're looking at here is this combination of volume and dose, and looking at it historically, that there seems to be some relationship with control rates, volume, and dose, but we kind of hit a maximum at 60 gray. This was another study that was done. It was a randomized study looking at radiotherapy volume, and it actually was very interesting because they randomized patients, 50 patients, to partial brain, 50 gray plus a boost, versus whole brain, 40 gray plus a 20 gray boost. And there was a suggestion that the partial brain was just as good as the whole brain, if not better, in particular when we're looking at toxicities. So again, we're looking at the volume, shrinking it down, and trying to figure out how we can better optimize our approach with radiation. So typically at this point in time, radiation standard therapy, off protocol and with no fancy anything. We use 3D planning, we can use IMRT, we can use conventional 3D planning. We have to delineate the tumor well based on CT and MRI scan information. We want to make sure that our plan is adequate as far as the normal structures, the whole brain, the contralateral hemisphere, brainstem, optic chiasm, all of the various things that radiation oncologists do. We ourselves do a peer review within our environment, but we are a large enough group to do this. We have physics checks and we have patient monitoring. This is what we apply to everybody, but we still want to do better. So, as the fractionated external beam was going on, some people looked at their experience with brachytherapy. Brachytherapy is planting seeds inside the brain, and the initial studies were done at UCSF. And they looked at a variety of different patients, non-glioblastomas and glioblastomas, and they found that there was an increased survival in patients with glioblastoma. So this supported this whole idea about adding additional radiation dose. And so as the brachytherapy is something that's technically challenging and it's really for a very limited number of patients, radiosurgery started to be looked at as an alternative to brachytherapy to give a very high dose of radiation on top of the 60 gray. Radiosurgery, as you know, was pioneered in the 1950s, and there's different systems that are available now. There's the Gamma knife, there's Linac-based, there's CyberKnife. So it's a very attractive opportunity to increase radiation dose to a very focal area. So when we look back at the studies supporting this, we have to be critical of that. So the rationale for radiosurgery is that maybe the radiation may overcome radioresistance, and that radiosurgery allows a very sharp fall off outside of the radiation field and the target, thereby reducing toxicity. It's done non-invasively, and it can be done as an outpatient. So very attractive approaches, but does it work? Here's another rationale. There's the same picture of the radiosurgery and the vascular niche, and that maybe those glioma stem cells that are hiding out there causing all the problems that we spoke about earlier, maybe by giving them extra radiation, they're going to be overwhelmed. So when we look at all of the radiosurgery efforts with the glioblastoma and high-grade gliomas, there's various different opportunities to actually add this radiosurgery boost. There's right after diagnosis, you have a patient who has a small tumor resected. Can you add radiosurgery here? And there is one randomized study looking at this. Then is there an appropriate time to do it right after the radiation as a boost upon completion of your planned 60 gray? Or is it appropriate to use it as progression? So this is kind of the approach that I thought about this. And unfortunately, there are really very few prospective studies. As I mentioned, there's one randomized study here, 9305, that was done through the RTOG, and we'll get into some of those details in a few minutes. But really, there is really no good, strong evidence to support radiosurgery at any other time points. There's retrospective studies which give us some food for thought. So the stereotactic radiosurgery, so this is, again, historically, one of the earlier studies that looked at radiosurgery for high-grade glioma, and it suggested there may be some benefit for anaplastic astrocytomas, and the median survival for glioblastoma was pushed out. So this is an example of some of the small studies that made us think about radiosurgery. And this is an experience from Sarkaria that looked at 115 patients from 3 institutions, and the median survival is 22.5 months. Again, these are pushing that overall survival a little bit further, but can we do it consistently for our patients? So one of the questions that has arisen is, why do we want to use radiosurgery before external beam? Why do we want to use it after external beam? And both approaches can be explored. So the reason why we might consider radiosurgery before external beam radiotherapy is that we can treat before the edema from the external beam radiosurgery occurs. So it might be a more better defined target, and that when the tumor burden is low, the surgeons have removed the vast majority of the tumor as much as we can, and then maybe radiosurgery is going to be more effective. Why would we want to do radiosurgery after external beam radiotherapy? And we exclude those patients who are not going to do well. We know that a certain percentage of our patients actually progress during radiation, up to 10–15%, and that maybe those patients are just not going to respond to radiation, and so we avoid treating those patients, and that maybe the glioma cells are actually in a more sensitive growth phase by actually having gone through this, the cell assortment and repopulation that the external beam may have done. And both rationales can be employed, but we don't know. We have only one study to support looking at the first approach. So this is the RTOG 9305. It was conducted from 1994 to 2000, and patients were randomized to radiosurgery after surgery, followed by 60 gray with BCNU, followed by further BCNU, versus 60 gray plus BCNU plus further BCNU, and they're randomized up front. They only included glioblastoma. They excluded those patients that were completely resected. So in other words, there had to be some gross tumor left behind. The tumors could not be bigger than 4 centimeters, and KPS had to be 70. So this does really take a well-defined population, and you would think the best of the best. When you look at the survival curves, there was no difference. So those patients who had the radiosurgery plus radiotherapy, there was no difference. The median follow-up at 44 months. There was no difference in overall survival. There was no difference in patterns of failure. Still, 92.5% had a local failure. They didn't have enough information of quality of life, and here were the doses that were used. So these were not shy doses. These were big doses. So this has been the study that's really, really made us not offer radiosurgery at the time of diagnosis, and I think it's a very compelling study because it was done very cleanly. But the questions are, how well was the study conducted? So in the radiosurgery plus XRT arm, there was 18% unacceptable deviations. Does BCNU and temozolomide, are they different? Do they have different outcomes? Excluding gross total resection patients, maybe you had some difference and impact on overall survival and the timing of the boost. Now, you can always argue about studies, but this study was done. Both groups were done randomized with no bias, and you cannot argue with the results that in this patient group there was no role for radiosurgery. So at this time, the only data we have for upfront, either before or after standard radiation, there's no support for the use of radiosurgery. Recurrent high-grade glioma in radiosurgery, there are no randomized studies for the evaluation of radiosurgery for recurrent high-grade glioma. There's a large number of retrospective studies, as you see here, using both linear accelerator, gamma knife. The median dose is anywhere from 12 to 20 gray, and the volumes are medium to small. And the overall survival after radiosurgery is consistently around 10–11 months, which is something. You know, this is a patient group that has actually failed after standard treatment and has progressed, and a lot of them may have already had chemotherapy. Yet after radiosurgery, we're obtaining about a 10–11 months consistently overall survival. Median overall survival from diagnosis, you're approaching, a lot of these are over 2 years. So this is compelling data that suggests that maybe there is a role for radiosurgery for recurrent high-grade glioma, which is shown from retrospective studies, but a wide variety of different institutions. Having said that, these patients are very well selected. They're not patients that have this diffuse involvement. There's probably patients who are younger, better performance status, so maybe there is a very strong selection bias in this group of patients. So recurrent high-grade glioma, the largest studies right now suggest that glioblastoma may benefit more than anaplastic astrocytoma, which is opposite from the earlier studies, that univariate analysis shows lower pathologic grades and smaller tumors do better, which is counterintuitive. Again, the conclusions from these studies are opposing on occasion. Another multivariate analysis showed that KPS, younger age, unifocal disease, and lower grade do better, which is intuitive as we know. But again, this is a bias from doing retrospective studies. And are we really picking out those patients that were brachytherapy eligible? Going back to the original idea with the brachytherapy, small targets, away from critical structures, usually good performance status, and maybe those are the patients that we're actually doing better with anyway. So, we still have a lot of questions for high-grade glioma and radiosurgery. What is the role for immediate SRS? At this point in time, there really is very little evidence to support the role of radiosurgery up front. One may argue that the platform is now changing from BCNU to temozolomide to the use of Avastin to the variety of different drugs that we're using. It's unclear, but maybe this is a question for future study to change the eligibility and to change the platform and then see how radiosurgeries impact that. Role for recurrent disease, there's compelling data retrospectively that it is a good tool to use. We use it at Anderson for selected patients where patients have a small area of local recurrence and they've had chemotherapy. What is the role for hypofractionated radiotherapy? This is another approach that can employ radiosurgery tools and give it in a slightly different fractionation, and maybe it's faster for our patients. Maybe instead of taking 6 weeks, we can do things in 1 or 2 weeks. Maybe that's a good alternative for these patients. How will new agents affect these outcomes? One of the issues from the 90 Gray experience was that there was a lot of radionecrosis. Can Avastin now reverse that radionecrosis or assist it, and then maybe we can get away with these higher doses because we have a supporting drug that will decrease the side effects from the radiation? How can we better target the areas of risk? Are we doing a good job of just treating the enhancing volume, or should we be looking at something else? And how do we look at post-SRS images better? The necrosis from the radiation can oftentimes look very much like tumors, so that also becomes a confounding problem in our experience. So that's it for high grade. So low grade glioma, there's a lot less data, and the standard of care across the board seems to be surgery. Radiotherapy is used for unresectable, recurrent, or high-risk disease. And the high-risk disease currently is considered patients older than the age of 40, tumors that are larger than 6 centimeters, and those tumors that cross midline, or those who have neurologic deficit, and astrocytoma versus oligodendroglioma. And you can see in this graph, the high-risk patients do have a higher chance of progression than the low-risk patients. This is the effect of external beam radiotherapy, not radiosurgery. And essentially what we notice is that, if you give radiotherapy early, the progression-free survival is improved, but overall survival is not. So this is something that's well accepted amongst the practitioners, that radiotherapy has a role in delaying progression, but possibly not in overall survival. So what's the experience for low-grade glioma and radiosurgery? Again, nothing prospective, some retrospective data, all very small, less than 20, 30 patients here. The size of these tumors were relatively small. You can see the largest was probably 4.2 centimeters cubed, so these are quite small tumors in areas of recurrence. The doses were all over the place, 16 to 50, 15, 10, 42, so a large number of different fractionation schemes and fraction sizes, and the follow-up months were about 2 to 3 years. Now this one here has 84 months, which is good. Outcomes, really kind of hard to interpret because they have overall survivals of 10 years and 15 years, but this is a group of patients that have a relatively long survival anyway. So it's really hard to know and to be able to extract information about the retrospective data on the role of radiosurgery in low-grade glioma. Some of these patients had recurrent disease, some of them had upfront disease, small volumes. But again, it's something that maybe we need to look at more consistently in a prospective study. So maybe low-grade glioma is better for radiosurgery. A well-defined small target might be a good choice, but oftentimes those well-defined small targets are the ones the surgeons take out anyway. So the number of patients that would actually be eligible for radiation are quite small. Those ones that the patients can't, that the surgeons can't access, that are near the optic chiasm or in the brainstem, those are the patients we don't necessarily want to give a big dose of radiation in a radiosurgery manner. So the role is a lot less clear for low-grade glioma. But on the other hand, they're less infiltrative, they're lower proliferative rates, so maybe the large fractionation might be a better way to go. But we don't really have any information that where I could actually say that we need to do radiosurgery over conventionally fractionated radiotherapy. Toxicities, typically our patients, they might have some headaches, nausea, vomiting, which can be managed. It really depends on the location and size of what we're treating. Radiation necrosis requiring steroids or surgery, in the high-grade glioma literature, it's up to 30%. So it's not something that we take lightly, because our patients will then have to go through additional therapies that may affect their quality of life. And sometimes our patients, especially historically, we were unable to get them off steroids, so they become steroid dependent, which is also can affect their quality of life. Now, with Avastin, who knows? We don't know whether that's going to impact our ability to deliver these high doses and repeat radiotherapies. So conclusions. So the role for radiosurgery for management of glioma, despite all our efforts, has not been established well. The one prospective study does not support its use. Retrospective studies do. There does not appear to be a role for initial management in high-grade glioma of radiosurgery. There may be a role for high-grade glioma after external beam or recurrence for selected patients. New targeted agents may provide a new opportunity for evaluating radiosurgery. And the role of radiosurgery in low-grade glioma is not well defined, and a single institution suggests moderate benefit, but it's in a very, very selected population. Thank you.
RedLANO, Red Latinoamericana de Neuro-Oncología.